I don't take much about the theory because PPHN can be divided into 5 zones. Number 1 zone is 2 hours talk about only pathophysiology. What is that? Only pathology. Then 2 hours talk about the only physiology. Then 2 hours talk about the 2 hours or more talk about the echocardiography. Then 2 hours talk about the medical management. Then 2 hours talk about the what is that? Autopsy and near future treatment. So like that, PPHN is divided almost into 10 hours talk.
No.
So I'm going to talk about today about the PPHN. First of all, I'll just thanks to Tamil Nadu NNF people, and at the same time ICH and HC, mainly organization team, they have taken a lot of pains to organize all these things. Okay, and just I am an instrumental person here. Thanks for all the organizers. First of all, I'll thank to GenWorks, Mr. Ganesh. He has designed it nicely. Prashant Gowda and Prashant and the Neo Gurukul team too. So my first one, the definition. Everybody knows what is PPHN or what is the newer terminology of the PPHN. This is not. Okay, how to? I think so they can hear. That's enough. Yeah, enough. Okay, it is just PPHN, persistent pulmonary hypertension. That means persisting, means previously it was there in the fetal life. It should have decreased after the birth, but it is not decreased. So that hypertension in the lungs, pulmonary hypertension in the lungs is persisting after the delivery. That's all, simple word. After the delivery, it should have been decreased, but it is persisting. The other word, the recent terminology since 10 years is coming, hypoxic respiratory failure. Hypoxic. Because of the respiration, hypoxemia is there, respiratory failure is there. Number 1. The second thing is the incidence and all those things theory. Just I want why we should diagnose in the echocardiography too early, because if you will leave this, neurological compromisation will be there. Not only that, the baby will have the more hypoxia. We people are going to use more ventilator induced lung damage, more BPD if it is any baby, or if it's a term baby, more lung damage, and baby will have a cardiopulmonary later in life. If it is not, baby will have a lung compromisation either in the development. If it is a preterm baby, under development. Okay, that is the reason echocardiography will do the maximum good things. The risk factor, everybody knows. Chorioamnitis, why infection? Everybody knows pathophysiology of infection. I told you more than 2 hours talk. And at the same time, meconium aspiration too. At the same time, perinatal infection, all those things are there. It's all theory once again. My talk is only the PPHN in the things. So what determines why I have put this? Just it is once again physiology and pathology. This one, see, that is PCW, means pulmonary capillary wedge pressure. That day I was telling in the shock class, what determines the systolic blood pressure? Systolic blood pressure in a normal human body or any body, it determines by stroke volume and contraction of the left ventricle. Stroke volume, how much blood is flowing, and contraction of the left ventricle will determines the systolic blood pressure. Then what determines the diastolic blood pressure? Diastolic blood pressure is mainly it is the blood inducing the pressure on the blood vessel. Blood, whatever the blood is there in the blood vessel, that is pushing, that is giving some amount of exerting some amount of pressure, that is called diastolic. But in systolic, vessel is giving some pressure on the blood flow. So there are two things. One is how much blood is going, then how much the systemic blood vessel is pushing against that is systolic. How much that blood is pushing, exerting the pressure on the blood vessel is diastolic. So here capillary is very, very important. Example, something like more blood is flowing like a vein of Galen is there, or TAPVC is there, or some amount of pulmonary stenosis is there, some amount of mitral valve is there. It is not allowing the blood to flow to the left ventricle. Blood is not able to flow. That is also can cause backflow, increase in the backflow. Once again, more blood in the pulmonary that can exert the pressure on the capillaries of the pulmonary and can cause pulmonary more blood and pulmonary hypertension too. Because many people, we people are missing the train. Because if the BPD is there or congenital pulmonary vascular stenosis is there, so if pulmonary venous stenosis, if you are missing, that might be causing in the either preterm or a term baby, we might not know what is exerting hypoxia. What is, I ventilated the baby very good. I have done it good. After ventilation, after increasing, baby might improve. Or minimal pulmonary blood pressure. And when we see there is a pulmonary, given long term, people have given even bosentan and sildenafil without diagnosing pulmonary venous hypertension. Please, dear friends, this is the new thing. Okay, but it's not no more new things. This is all the things we should remember. Pulmonary interstitial glycogenesis, alveolar proteinosis, lymphangiectasis, because this is all a primary pulmonary hypertension. There is a pathology in this. We have sometimes we do miss. Okay, we can diagnose only because of the either lung biopsy alive or after the autopsy. Okay, this is also, do you think pulmonary hypertension can come without any problem? If there is no respiratory distress, then you should go for a red signs. See, there are heart problem might be there. So many problems. This is all, once again, I told you, just I want you people to remember, easy to remember this one. If you don't remember, it's very difficult. What is the difference between echocardiographer and the cardiologist? Echocardiographer will see what he wants to see or she wants to see. Okay, what is the pathology? She might learn either 25% or 50% of complete pathophysiology of that heart. But as a cardiologist, he should read about complete pathophysiology of the heart, as well as where, what if the pressure is more towards the right side, where it should go to the left. So right to left shunt. So what all chambers will dilate? If the chamber dilates, what happens to that mitral valves? So everything cardiologist will remember. Accordingly, he will diagnose. So he will take, if mitral valve is having the problem, what is the diastolic problem in the left ventricle? So that is the difference between the echocardiographer and cardiologist. Okay, see, maladoption. Adoption means adopting the baby. Means we are trying children, we don't have the children, then later we are adopting. So like that means at the time of birth, everything was okay. But after the birth, because of some hypoxia, pneumonia, aspiration, so PPHN is come. So adopting, after till the baby is delivered, it was everything good. So later it has not happened because it is not dropped. PPHN is not dropped. So why asphyxia? Maldevelopment means before that one, because of the development. So antenatal, ductal closure. Underdevelopment means PPA, preterm baby. So chronic lung disease, it's not developed properly, or something occupying. So it is, that is all you should remember. How to underdevelop means preterm baby. Remember, maladoption means after that maldevelopment. This is the thing. It's a beautiful thing. Please, everybody might have read in the theory. Please go through this. Same, I have put this. Okay. Please remember, somebody might ask when pulmonary arterial pressure will fall. Usually it should fall within 1 to 2 months. It should be below the 25 millimeter of mercury. If it is not, if it is more than that, that's what we diagnose mild, moderate, severe pulmonary arterial hypertension, more than 25. It's coming little late. Okay, number one. Number two, what we have to remember is This is a beautiful. Sir, why echo is necessary? Can I do it like this? Preductal, postductal difference, oxygen saturation. Yes, you can detect. But just I am asking you, if preductal and postductal difference is can be, if there is a big VST is there, big AST is there, even it might be congenital heart problem. So, but you are looking into the preductal, postductal. That time even difference might be more than 5. So you cannot diagnose it's a PPHN. It should be very cautious. Then pre and postductal blood difference. Anybody can tell me, can think why blood pressure is very important, preductal, postductal? Just think in your brain, please. Suppose if it is a duct dependent lesion, postductal BP will be usually higher if it is a duct dependent. So that time preductal BP will be low, but we will overlook that BP. That is the reason. That is the reason whether it is a PPHN, whether it is a duct dependent lesion is very important. So that is the reason echocardiography will play a really major role to diagnose whether it is a PPHN or a congenital heart problem. Okay, my talk is completely depending on this slide today. My talk. Please, if you have a mobile, take a snapshot or store it. Okay, I have divided the PPHN. Take this baby just outside because my talk might make the baby up. My decibels are little higher. Later babies. Okay. See, I have divided the diagnosing the PPHN or pulmonary arterial pressure or higher pulmonary vascular resistance into the chambers like this. For you people to remember, it is really easy. Can I do all these things? Or should I do all these things? Or which is necessary? Which is having repeatability? So many questions are there in this. First of all, we'll come to the right ventricle. Right ventricle, if you will take it, tricuspid regurgitation is the one. It's a gold standard to diagnose PPHN is there or not. So everybody should tell me tricuspid regurgitation can be diagnosed in what all views? Number one, always when you put the Doppler, it should be parallel. It should not be perpendicular. Or angle of insunation should not be more than 20 degree. So if it is so what all the views it is better in tricuspid regurgitation? Apical view, 4-chamber view, it is very good. And see that intraventricular septum should come to the center of your V, means wherever you are seeing apex. If it is slightly tilted, you might not get a proper TRZ because angle of insumination should go, it might go more than 20 degree. So try to bring it into the center. So that is one catch point here, or point to teach, or a teaching point 1. Then suppose, sir, I am not able to get in an apical view, any other view, parasternal long axis modified view where we will tilt the probe towards the right hip. That time we are finding the tricuspid valve. That is the 2 best views you can detect the tricuspid regurgitation. Number 1. What is, once you detect the tricuspid regurgitation and put the Doppler, either continuous wave is very essential. Sometimes if you put the power wave, what happens if the power Doppler, that is called pulse Doppler, cannot diagnose or detect or pick up more than 2 meter per second wave, that velocity. But continuous wave Doppler can pick up any velocities. It can continuous wave Doppler. So that is one teaching point 2. Pulse wave Doppler cannot detect more than 2 meter per second. Continuous wave Doppler can detect more than 2 meter per second. So we are going to use continuous wave Doppler. Once you diagnose the Doppler TR, it is going away from the probe. So in the line of the Doppler, it will come below like a tongue. Remember, like a tongue. If it comes into the tongue, I'll show you what is RV-SD ratio. Everything I'm going to tell you. Because this one needs actually 2 classes. But if you are interested, I can take into the next class also. Slowly we will postpone. And TR, RVOT, everything I am going to tell you today. Please take a snapshot of this slide. I was telling accuracy depends on the quality of acquired TR jet. What do you mean by quality? I'm going to show you. Okay, it is very, very important. Angle of insonation, I was telling you. Apical 4-chamber view, I told you. Short axis, yes, you can diagnose even in the short axis, but 2 things are very, very important and better. Okay, right ventricular failure. Do you think it is good? We cannot. If the right ventricular is failuring, we cannot. Tricuspid valve regurgitation cannot always be observed. Cannot always be observed, remember. So that is the reason we are having other things like left ventricular, pulmonary, all those things we do see. Okay, once again, last word, please copy it. Teaching point. Tricuspid regurgitation we might not find all the times. That is the reason we are able to see this other things. Okay, now I am going to this. Today there is some technical errors happened. I am not able to show you in my cursor. So I am trying to show you people like this. Please adjust today. See, apical view. Sorry, I put the probe into the reverse. Okay, parasternal Lang axis. So TR jet. Can anybody tell me what is the problem here in 2 pictures? First picture and the second picture. Number 1, first picture, you can see the tricuspid regurgitation like a lower projection. It's a full tongue, like a tongue. But second picture you can see, but it is not completely, you can trace the things. You might get an underestimation. See here, same thing, you are able to get underestimation because center one is black. You are not, angle of insonation is not correct, or because of the respiration and because of the heart beat, the whatever you have kept that continuous wave Doppler, it is moving. So you are not able to get the full trace. If you are not getting the full trace, so you are not able to get the proper velocity. So modified Bernoulli's equation, you can see number 1 in the picture number 1, that is the tip. That is the velocity square. So 4 is a common. Okay, what is the pressure? Example, if it is a 4 into 4 is equal to 16. 16 into 4, whatever the things will come, that is the pressure. Always try to add 5 to 10. That is called right atrial pressure 2. Suppose if it comes 50, so 50 plus either 5, 55 to 60. That means it is a very, very more than 60 is a severe PAH. 25 to 45 to 55 is a moderate. More than 55 to 60 is a severe PAH. So remember that this is called a modified Bernoulli's equation. So once you get the TR, I told you how to take the TR. Once you take the TR, go to the calculation, press that calculation, you take that maximum velocity. Machine itself will give what is the pressure gradient, because machine will have an inside calculation. Okay. What is RVSD ratio? Please check this. It's very important, dear friends. You have taken the TR. Wherever the TR is coming, that is called systolic. Wherever the in-between gap is coming, diastolic. So SD ratio, if the ratio is increased more than 1.3, it is very, very dangerous, because when you are seeing the TR, immediately you should see this also. If it is less than that, 0.6, it's good. 0.6 to 1 coming near, it is danger. More than 1 is severe. More than 1.3 is, you have to put on ECMO or baby will pop off. So remember, this is called RVSD ratio. Okay, now come to the second one. You have taken the tricuspid regurgitation. So you calculated the velocity. Only I am talking about velocity. Example 4. Okay, you have taken the velocity 4. Then you have taken the VTI. You know how to take the VTI. Yesterday I was showing you how to take the VTI of aortic. Where we will take the cardiac output of the LU. Yesterday I showed you how to take the cardiac output of the left ventricle, or LVO, or cardiac output. The same thing, right ventricular outflow also you can take, or you should take. See the VTI. So whatever the velocity, 4 divided by VTI is 17. So like that, I'll show you everything today practically. Value, if it is more than 0.14, indicates a severe PAH. Because I am going, once TR you have taken, you have done the TR SD ratio. Once your TR taken, immediately you should take RVOT, then calculate that. So I am going in flow, means please, whenever I am talking, please there with my, your frequency should be there with my talk, and it should match. If you are seeing only slides, you will miss it. First I have taken the TR. How to take the TR? I told you. Once I took the TR, then I put it, what is the pressure? Suppose after taking the TR, if I am more enthusiastic, I have taken the TR with VTI of the RVOT. It should not be more than 0.14. Okay, then when I take the TR, SD ratio. So SD ratio is very, very dangerous. I told you it should not be more than 0.6 to 0.8. If it is more than that, more dangerous. Then that also I have taken. Then come to, when you are seeing the parasternal short axis, you are, parasternal, whatever the axis, parasternal short axis after the papillary muscle view. So you should see the configuration of IVS. So whether left ventricle is round or D-shaped, D-shaped, or it is completely crescentric. This is very important. It's like this. Please see this. Curvature. It's a flat D-shaped left ventricle. Then it is a crescentric type of left ventricle. If it is there, it is very, very, very dangerous. That also, if I will find the baby, I am going to get it. Then come to, naturally, you people should remember, that's what I told you, difference between echocardiographer and cardiologist. If the pressure is more in the right ventricle will enlarge. If it is enlarging, right atrium also will enlarge. So you should have a suspicion why right atrium is enlarged, right ventricular is enlarged. Then you are going to see the, it's all eyeballing, means visual examination. Okay, if it is enlarged, you will see tricuspid regurgitation. If you'll see tricuspid regurgitation, you are going to see the SD ratio. If you'll see SD tricuspid with VTI, see it is so easily, I am talking about only right ventricle. Very good. So now we will go after that slightly one more. This is called fractional area change. Suppose, imagine blood is flown more to the right ventricle. So diastole is increased. Pulmonary hypertension is not there. Completely during the systole, it will flow to the pulmonary veins. Once it flows to the pulmonary veins, so right ventricle, I don't know why echoing.
देखना पड़ेगा ना पेशाब देखना
I think so. Somebody switched on their speaker. That is the reason it is echoing. Prashant?
Yes, sir. Wait, taking.
Please, can you switch off because it is echoing? Yes. So now, can you hear us, Prashant?
Yes, sir. Yes, sir. Go ahead, sir.
So, right ventricle is enlarged in the diastole. In the systole, it will come down. So that if it is 100, if it is an 100 in systole, if it is 50%, it's good. Suppose in the pulmonary arterial hypertension, in the diastole, right ventricle is enlarged, but in systole, it is only contracted 80%. That means it is contracted only 20%. So that is the reason. As it decreases, that means right ventricular is failing. That is called fractional area change. Once again, let me repeat. Suppose right ventricle is enlarged in the diastole. If there is less pulmonary hypertension, all the blood will go to the pulmonary circulation. In the systole, systole volume will become very less. Suppose if pulmonary arterial hypertension is there, right ventricle cannot push the blood to the pulmonary. That time, even during the systole, from 100%, it can only decrease by 2 centimeter. So 10 minus 2 is 8. So normally it should have become 4. So it is, since it is 8 means 2. So as the values are coming down, that means more problematic. So this is what I am telling you. This is also can be seen in 3 or 4 chamber view that I will tell you. See, this today I am going to teach you. This is a myocardial performance index or TEI. This I am going to tell you, even if I'll tell, if you don't see, it is difficult, but it is very, very easy, dear friends. Just imagine you are taking the heart into the apical 4 chamber view. Okay, remember you are taken from apex, put the probe into the apical apex. You are started viewing 4 chamber view. You have put your continuous wave Doppler or pulse wave Doppler in between the mitral valve, aortic valve. Suppose if you want the left ventricular MPI, myocardial performance, how the left ventricular is functioning. Suppose if you want right ventricle, you are putting the continuous wave pulse or continuous wave line or pulse wave in between the tricuspid valve and RVOT. That time what happens? Blood is flowing from the tricuspid area. It will come as an E and A wave. It's towards, this thing. Then the blood is flowing away from the flow, this thing. It is coming like an tricuspid or RVOT. So in between that, I'll show you very clearly what happens. Remember, what happens if the pulmonary arterial hypertension is there? So contraction time will increase because heart has to take more time. And relaxation time is also increased because blood is flowing, taking long time for the filling. So once it both increases, that means MPI also too increases. If it is increasing, it is very, very dangerous. So that's what I'm going to tell you. If it is, see, it is more than 0.4 above, That means if it increases, remember why it increases MPI? Contraction time takes long time. That means stress on the right ventricle. Then even relaxation time will take a long time because of the force on the ventricle. If both are increasing, naturally myocardium is under the stress. So that's what the values are increasing. See, some people, sorry dear friends, I'm not talking about individual here, anybody. After the teaching of 2 weeks in our hospital, some people are mugging and going. MPI increases, but if you will mug transient memory, don't mug or don't picturized, you should not have a picturized memory. You should think why pathophysiology, basics. Then you need not mug, because you will feel it's like a mathematics. Like a Shakuntala Devi, what she tells, mathematics is my ice cream. I love it. So here also, why, if you will know, that's what difference between echocardiographer and cardiologist. Okay, dear friends, next I'll go. So now you are still in the right ventricle, still in the right ventricle. So what happens in the right ventricle or right atrium? There is a AST or PFO will be there. If more blood is coming out from the TR to the RA, where it should go to the left atrium. So that time right to left shunt, it will come blue. Suppose if it is not coming, not going from the right atrium to the left atrium, if it is not going, that means left atrium to the right atrium, if it is coming, so still PAH is low. The time when you will see near the AST blue color, please dear friends, have a caution. Either you are treating severe PAH or you are treating congenital heart problem like TAPVC. TAPVC, either any type, either cardiac type, it is coming and joining to the coronary sinus, or any type. Okay, obstructive, non-obstructive, any type, but non-obstructive is more. So dear friends, or PPHN due to non-cardiac causes like a vein of Galen aneurysm or anywhere aneurysm. So where blood is flowing more. So because right atrial pressure is more, it is pushing the blood to the left atrium. So when you are putting the probe onto the subcostal area and viewing the right atrium, AST or PFO, if it is flowing to the right to left, please think it is PPHN or congenital heart problem, otherwise proved. Okay. So please dear friends, don't forget that this is teaching point in this slide. This is a top say. Top say means it's really difficult, dear friends, for the beginners. Even I'll show you how to do this too also, but I don't know whether I can show or not, but time is short. Actually, PPHN needs minimum 6 hours echocardiography in brief. See, I am just talking very fast because my hour is only 2 hours. In that 10 minutes, I already ate enough. So please, dear friends. So I am going fast. However, if it is possible, I'll take in the next class too. So top say. That means tricuspid annular plane systolic excursion. Once again, go to the apical view. Go to the apical view. See the where I am putting the cursor is tricuspid annular, means where it is hinges is there. Hinges means what? Door hinges. In our house, doors are there. Door is held by, it is held by what? Some hinges. Some iron thing is there, no? Yes. That here also that valve is attached to the myocardium, no? Put that place. Your M mode, that line should be there. Press it. During the systole, during the diastole, what happens? Many people, if you are new to this, so during the diastole, what happens? Heart will fill. Once it fills, tricuspid area will come up. because more blood is there, it will like a balloon, it comes up. During the systole, all the blood goes outside and muscles are contracting towards the apex, it comes down. It comes down. So remember, I don't know, my video is also you're not able to see. I'm sorry today. Okay. So during the systole, it comes down towards the apex. That, what is that? Hinges of the tricuspid. During the diastole, it fills, it goes up. That is, distance is called tricuspid annular pansystolic excursion. That means going up and down. It should, see, I told you that Z scores, everything I have given you. Okay. Everything I have given you, even preterm baby, it's slightly lower. Okay. 0.6 to 0. I have given you all those things. If anything goes more than 2, 1.8, because there are more than, I have gone through more than around 12 to 14 studies about the TAP TOPSAE. In that, everything more than 1.6 to 1.8 is more dangerous. Some books, some authors will tell more than 1.4 is dangerous. So remember, dear friends, okay, that means excursion is not there. That means diastole and systole is very, very minimally moving. Okay, next. Now I spoke about, completely I spoke about right ventricle. I want you people to see once again my first slide. Just go through the right ventricle. Everything I have covered. Memorize yourself. Memorize it before I go to the left. TR, RVST, TR, RVOT, VTI, RVOT decreased. RVOT means right ventricular outflow tract, means output. That's VTI itself is decreased. You know VTI, velocity time integral, it is decreased. Why decreased? Because more pressure on the pulmonary side. Right ventricle is not able to push more blood. So stroke volume is decreased. That's called IVS configuration. I told you. First is round, then flat, then D-shaped. Sizes increased. Atrial shunting, I told you. TOPSAE, I told you. MPI, myocardial performance, either left ventricle or right ventricle. If it is relaxation time, contraction time, both are increases, MPI will increase. If it is increases, MPI, you people are asking me to repeat. Once again, I will show you in the live demo. I'll be talking that time, dear friends. I will talk. Definitely, I will talk. Okay. Otherwise, what we will do, if Kamal sir gives the permission, I can take pulmonary artery, because this is the bread and butter for the neonatologist. If Kamal sir is giving the permission, sir, take this PPHN and PDA and that next class. I can take 2 next class. So we can cover all the 3 things once again, recap, if he gives the permission, because he has put the schedule. This is the things Dr. Dinakar is requested us to go ahead. So I cannot do anything.
No, sir, we can adjust, sir. We can adjust.
Okay, sir. Okay, TR. So MPI, people are asking, sir, I will show you live, sir, how it is. How? Sir, put first, MPI means myocardial performance index. So left ventricle myocardium, right ventricle myocardium. How ventricle globally it is pushing the blood towards that outlets. Left ventricular should push the blood to the aorta. Right ventricle should push the blood to the pulmonary. Suppose if pulmonary hypertension is there, it cannot push the blood. That time what happens? Right ventricle feel a strain. Whether globally right ventricular is having problem or not. Globally left ventricular is having problem or not. To diagnose, we are doing myocardial performance index. So how to do this? Put your continuous wave, first you put the probe into the apical view. After putting to the apical chamber, 4 chamber, which ventricle you want to choose it or want to know that ventricle function, whether it is left ventricular or right ventricle. Imagine now you are doing the right ventricular function. So you are putting the pulse wave Doppler or a continuous wave Doppler, whichever it's possible. Better to put a continuous wave Doppler. Better to put a continuous wave Doppler, I repeat. In between the pulmonary, that's called RVOT, and tricuspid valve. So press the continuous wave Doppler. You are going to get the Doppler waves. Whichever the wave coming above, it is, that means whichever the wave is coming above, that means the blood is flowing towards the probe. So which can flow from tricuspid only, it can flow. If there is a tricuspid, whatever if it is a tricuspid, normally flow is there, you will find early filling, early systolic filling and atrial contraction, E and A wave you will get. At the same time, blood has to go through the pulmonary artery also, pulmonary MPA, no, it has to go through the RVOT to the pulmonary artery. So it will go. That will come towards the below the line, means away from the probe. So you got both. Now you got both in a single image. When you get in the single image MPI, so you are going to find in between the MPI and this thing, first and last, there is called IVRT, IVCT. IVRT means isovolumetric contraction time, isovolumetric relaxation time. That is before and after the E and A wave. That you measure it, sir. Then you measure the whatever the ejection time, that is RVOT time. So IVRT plus IVCT. It's not coming. No, I am putting this screen only from that time. See now? Can you see the screen?
We can see, sir. We can see, sir.
No, sir. No.
Okay. Okay. So I will, sir, once if I'll show you, it is very easy, sir. MPI, because I will show you, sir. I don't know where it is, dear. Can you show me? It's come like this. I have to do. Okay, can I do this? Okay, like this. Okay. Okay, ma. Yeah. Sir, if I'll show you, it is more easy, sir. See, this one only I was telling you, sir. This one only I was telling you. This is the other way to diagnose MPI. You can take only pulmonary ET and only MR. Two methods are there. You can take it. Sir, I will show you live, sir. Then you will understand more better. Okay. Now we will go to the, because today we are going to see the two things. I told you about completely right ventricle problems. Now go to the left ventricular problems in the PPHN. If the blood is not flowing, preload is not there for LA to the LV, what happens to the cardiac output of the LV? So cardiac output stroke volume is very less. So LV output will become decreases because of the PPHN blood is not able to come. That is number one. Second thing, LV LA size will be decreases. 2. Number 3, what happens is, once again MPI of the LV is decreased. Then I told you, What happens if IVS? IVS means intraventricular septum is compressed. Right ventricular more pressure, it is compressed. First D-shaped left ventricle, then crescentic tape, left ventricular more pressure instead of circular. So that is one. Then there is called LV systolic eccentric index. It's a big words, but it is very easy, dears. You need not worry at all. You need not worry. See what is this? See here D1 divided by D2. So what happens if D1 is increases, because the above black what you are seeing is right ventricle. It is pushing the IVS. IVS means intraventricular septum. That time longitudinal view, longitudinal axis of the D1 slightly increases compared to the D2. That time what happens is it becomes more than 1. D1 divided by D2. D1 divided by D2. If it is more than 1, that means severe pulmonary arterial hypertension. It is a simple big words. Because I told you eyeball examination, that means immediately in your visual examination, if you are seeing right ventricle is pushing that IVS, then D1, D2 you take, it's coming to more than one, it is dangerous. That's all. So in left ventricle, what and all you saw, LA, LV size is less. Left ventricular cardiac output is less. Then, so left ventricular eccentric index is, if it is coming 0.8 to nearly 1, it is dangerous. Otherwise, it should have been equal because round. Okay. Next, I'll go to the slightly. I'll talk about the PDA because I think so. I can show only that much. If time is there, I'll finish even pulmonary too. Yesterday, I was talking about the PDA. Hope so. I showed you this. So ductal shunting is there. Right to left, if it is more than 30%. What is that, sir? Please just observe yourself. In the first image, my left hand. So where T is there, where transductal T is there, below that image is there. There, right is very small, left is very big. Come to that other side of the picture. Right shunt, that means downward. Shunt is more compared to the complete left ventricular flow, PDA flow, systole and diastole. Complete cardiac flow, you will take example 100 milliseconds. In that, right should not be more than 30 milliseconds. If it is more than 30 milliseconds, think that is an other indicator of you are dealing with either congenital heart problem. That means right to left shunt duct dependent congenital heart problem. Dear friends, let me tell you once again. If in the PDA, if you will see right side in the whole cardiac output means systolic and diastole. If it is 100 milliseconds, example I am talking. Okay, the right side flow should not be more than 30 milliseconds, means 30% of that cardiac output. If it is more than 30% of that cardiac output, think of severe PPHN, think of right-sided duct-dependent cardiac problems, otherwise severe TAPVC or other cardiac problem. So it's a teaching point in this slide. Why I am telling teaching points? I am a teacher, I am a professor, so I am telling my students, it's become my habit. So if any consultants are there, I am very sorry, dear friends, because only to make you, okay, please concentrate on this. That's all I am talking, dear. Okay, then please go through the last one. Via ductal flow is not reliable, but however, it is very important. See, you people can see what happens here. It's purely right to left shunt. Many people, we do miss this. Sir, red only, no PDA. Why blue has come here? Sir, that blue is MPA. Because aorta will also blood will come blue, you might miss. Please, dear friends, don't miss blue. Blue is very dangerous. If you are seeing it, please have a concentration. What could be the reason? If you are seeing only blue and PDA is there, suspecting, go to the atria. Atria is also blue is there, right to left shunt is there. Then go to the structural problems. Then just give a code blue. Code blue means you understood. Danger. So blue is code blue. So I think so, probably this one is very important. Let me tell you today. Pulmonary, but it is, if you are beginner, you will think, oh, this is too much, dear. If you are already doing, it is good. If you are a beginner, it is difficult. Now, please, dear friends, if you are a fellows or anybody is there, please take down the paper and pencil if you have with you. Please take down the pencil paper if you are having with you. Otherwise, please. Okay, see this slide. Can you see this? It will come. It will come. So memorize now about the right ventricle what I told. Memorize now left ventricle what I told you. Memorize now PDA what I told you. Dear colleagues, see one thing. Many things in theory, this might not be there. When you read echo, you will get more knowledge. More knowledge. Because each subject will give us a more enthusiasm to learn and know the things. Right ventricle, PDA, LVO you have learned. If you want to memorize, please memorize. Okay. I'll go to the pulmonary artery, just theory. Now we are going to talk about the pulmonary artery, how it will be. Yeah. This is the one. Yeah, okay. Yeah. Now, pulmonary artery. First, I told you right ventricular, what all the things. Then I went to the left ventricular, what all the things. Then I went up suddenly to the PDA. Then I am coming back to pulmonary artery. Pulmonary artery diameter. Naturally, what happens if the severe PAH is there? The size will become dumma, mota. It will become very big. Yes or no? So it might become like this. You are with me? Yes or no? Aortic valve and MPA. Because why it is becoming more big? Because it has to accommodate more blood what RV is pushing. But MPA cannot push to the RPA and LPA. So blood is not going. What happens here? 99% all the blood will return. Some amount of blood is retaining in MPA. It will become very increased in diameter. Then pulmonary flow pattern. What do you mean by flow pattern, doctor? Normally, the blood should flow very smoothly like this. See the first above, smoothly it should flow without any interruption. Suppose in between somebody is strangulating that blood. What happens? You can see the lower one, it is a W, or it is very sharp compared to the above one. Compared to the above one, it is very sharp. Because usually what I am putting, the above one is also mild PAH is there. But usually pulmonary artery will become very smooth curved like a TR. You understood, no? If it is the tip is very sharp with the once again W shape spiking like a mountain, it is there. That means somebody is strangulated, means somebody is pushing the blood back. So flow pattern you understood. So why I am telling each and everything very like a small, like an animation, because animation memory will keep that cells more stimulated. How Dr. Dinakar learned this? Because for the kids, everything they are showing into the animation way. So they are interested, they will remember for a long time. So what I thought is, why can't I tell or teach like an animation such that our brain also can might retain. I am sorry. That is the reason I am also talking. Please memorize like an animation pictures. Now, pulmonary regurgitation. Okay, MPA is dilated, sir. I agree. Sir, flow is slightly restricted. I agree. Then what happens? Blood is started flowing back from pulmonary, whatever it is pushed. Yes or no? Pulmonary artery, blood is flowing back. How you will know? How you are going to diagnose pulmonary artery blood flow? Anybody can tell me which view you are seeing the pulmonary artery? Which view is the best view to diagnose pulmonary artery? Main pulmonary artery, pulmonary valves. If somebody tells me 3, I am very happy. I should not tell something I'll give you today evening, because evening means people will think something. Okay, parasternal short axis view is excellent, sir. Next. Anybody?
Ductal view.
Parasternal long axis, superior view towards the left shoulder where pulmonary artery is opening. Yes, sir, that is true. So parasternal long axis, superior view, parasternal short axis. Yes, I agree. Then any view? Then subcostal where pulmonary you are opening, subcostal view you can see. But which view is better to take the pulmonary flow or measurements? It is parasternal short axis view. Okay, now just to make you more refresh, then only 2 is there. If you are getting it today, I am very happy, dear friends. See what is RV, PEP, RVET. Remember, RVET means right ventricular ejection time. Means how much blood is ejected from right ventricle through the pulmonary artery. What time it took. Suppose it took, you think it is taking 100 milliseconds. Think. So what is right ventricular pre-ejection period? Before ejection, it should build the pressure. It should build the pressure to open up the pulmonary valve against that pulmonary hypertension. That time, how much it is taking, that time is to RVET. You understood? Right ventricular pre-ejection period. Because if pulmonary hypertension is more, that preparation to overcome that pressure is more. If it is more, that means very dangerous. If it is less, it is very good. So what happens if RVET is 100? If it is taking 75 milliseconds preparation time, that means RVPEP is to RVET. Means pre-ejection time is 75. It is, if it is more, that means it is dangerous. How much more, Dr. Dinakar said? That 0.3 to 0.4. It is acceptable. It is acceptable. If it is more than that, it is dangerous. Come to the other one. Now you understood what you mean by right ventricular pre-ejection. So you are with me now. Come to the other one. Here I am going to tell you reverse. Don't get confusion. This is RVET, everybody knows. Remember, it is 100 milliseconds. Remember means always 100 means it is not a normal value, dear friends. To make you one round figure, I am putting 100 milliseconds. What is pulmonary artery accentuation time? Accentuation means how much time it reached the peak. That means this is the one. See here, pulmonary artery accentuation time. Normal what happens? I told you it is like a very smooth tongue shaped. TR is tongue shaped. Here also it is smooth. But see the second image, B image, it is sharp and it is a mountain. So mid systolic notch is also there. That's called mountain. I was telling, or some people will tell reverse flying M. So many things. Just imagine sharp and notch in between is telling us the pulmonary flow pattern is telling us there is some pulmonary arterial hypertension. So remember this word. Now accentuation time means see that PAAT difference, that maximum peak when it has reached from the start to this divided by 100. Suppose if it is reached in happily, there is no pulmonary arterial hypertension, peak is reached at 50 milliseconds. So that means it is taking its seat time very happy. That means no pulmonary arterial hypertension. So what happens? 50 divided by 100, it is 0.5. Suppose because of the severe pulmonary hypertension, but it is not able to reach that peak, but it is reached somehow, means decreased PAAT. That means there it is increased. I told you where it is. I told you RVET. That pre-ejection period is increased dangerous. Here it is decreased is dangerous. So just remember, I'll show you practically how it looks also. And this is a new thing why I am telling postgraduate, remember with the chambers, because many articles, many books are telling according to the pressure for a big cardiologist, we might not remember. As a neonatologist performing echocardiographer, we are not a cardiologist. So for us, what we need, we should remember. What makes us more simplifying and learning and remember for a long time, we should remember. So I told you right ventricular what is there, left ventricular what is there, PDA what is there. Then I told you pulmonary artery. First pulmonary artery, what I told you, MPA is increased in size. Then what I told you, MPA regurgitation, what is there. So remember this is a beautiful thing. See, this is the one I was telling RVEP. See here one, I cannot show you here because I'm having the problem. You can see there is one purple color dot is there. But RVPEP need a ECG leads also. But however, there is in between one small whitish thing in there that you can do it. But literally we need a ECG thing. That is the one thing, it's very important. Come to the pulmonary, sir, can I diagnose with the pulmonary regurgitation? Can I diagnose? Yes, you can diagnose with the pulmonary regurgitation, same like TR. Please see the same calculation. Same calculation will also hold good. But is it accurate? Yes, it is also accurate. There is no harm. So this is my talk is over. Okay. So all the things, this is once again, remember, I'll take only 1 minute now. My dear friends, pulmonary vein stenosis, please try not to miss, because I have kept this slide in the last, because if you are a beginner, it is difficult. Try to learn from your pediatric cardiologist. Sir, can you show us what is it? Try not to ask an adult cardiologist, because neonatal pulmonary vein stenosis is slightly S wave, D wave and A wave is slightly different from the adults. Okay, they might not remember what is the normal values. They know that it should not be more than 1 meter per second. Okay, whatever it is, try to learn from the pediatric. If not, at least read some books and ask from him, then learn yourself like an amateur, like Dr. Dinakar. Amateur, because, okay, this is a 10 commandments. Please go through. I'll give you 2 minutes. Can I go to the practicals?
Yes, sir. Yes, sir.
Kamal sir, can I go to the practicals?
Yes, sir. Yeah, you can.
Yes. Yes, sir. Yes, sir. Please, sir. Please hold on, sir. Yeah. Whom is Dinakara? Dr. Prashant?
Dr. Prashant.
Prashant? Dr. Prashant?
One second, sir. He's coming. He's joining. He joined. Actually, network some issues there.
No. Prashant, I am talking to you only.
Yes,
Prashant,
sir. Yes, sir. Yes, sir. Tell me.
please, can you switch my mobile, Dr. Dinakara Prithviraj's mobile
Okay.
for the video,
So it's there, sir. You can show. You can open. Permission is given.
Okay. Really? How to switch on this video? Down that side, camera.
Came, sir. I can see.
You can see, Baba, hidkoma. Well, make it that one as an big.
Yes, sir. It's coming.
Okay. Tell us what is. First, I did my hand wash. I am once again cleaning my hands with the sterilium, number one. Okay. So I told you this is a gel. This is a condensed water with agar. So please try to clean it. Try to clean it as much as possible and don't leave anything, because if it's a government or somewhere, even rats will come and shit and urinate and do all those things, because this is sweet. Okay, dear friends, number one. Audio also switch on here. Audio also. Here, audio. Audio ಮಾಡಬೇಕು. Okay. So number one, I am putting once again the gel. Danya, ಹೋಗಿಲ್ಲಿಂದ ಹೋಗಿ ಬ್ರೂನು ಹೋಗಿಲ್ಲಿಂದ ಬಿಡಲಿ. Okay, now I am changing to this cardiac mode. Okay, I am changing to the pediatric. Okay, I am changing the probe to this. Either I might take if it is a smaller 1 kilo or baby or something, I can use a neonatal probe. It's a little, I think so, baby is around 2.8 kilo. I'm trying to use this. If it is it's a little real pediatric size. If it is, I'm not comfortable, I'll try to use this. Okay, number one is over. Now I have put the probe into this thing. My today's talk is only PPHN. I told you all the angle and everything. I don't want to go other things. Once again, basics and other things, I don't want to do it. So first one, I am going to the right ventricular functions. First, what I am going to see the right ventricular. This baby is a delivered. No. When it's delivered, what time?
8 a.m. morning.
Today, 8 a.m. morning. I don't think this because I don't have any PPHN cases today. But I'll show you how to see the PPHN and how to analyze the things. Okay. Number one. First, what I am going to see is a tricuspid. Sorry, right ventricular. Please see my face. Right ventricular, I am going to show you. In what way right ventricular I am going to show you? Right ventricular, I am going to show you in number one, in apical view, 4-chamber view. What I want to see is tricuspid regurgitation. Then parasternal long axis view, where I'll tilt the probe towards my right hip, means baby's hip. Angulation. There I'll get a tricuspid valve. There I'll put the color. Then I put the continuous wave Doppler. I'll try to take the TR if it is there. This is the one I am going to show you. Please come with us. And this one I want to show you like a pediatric because I am used to like an anatomical view, not like an adult. And my probe is towards the left side. My probe marker is towards the left side. Here also it is in the left side. It is in the left side. This is also left side. So whatever I get the structures here is left. So that is must orientation. I think so you people can see. So you people can see very clearly the right ventricle. Yes or no? Please, in case if you are not able to see, let me know. I'll put my cursor. This is, once again, let me tell you. See, always I was telling very clearly, dear friends, where my cursor is there, this is intraventricular septum. It is try to bring it to the center. Try to bring it to the center. I brought it into the center and I brought it into the center. So this is all right ventricle, right atrium, left atrium, left ventricle, mitral valve, tricuspid valve. So tricuspid valve is slightly lower, mitral valve is slightly higher. In this one view, I can see the moderator band. I can see the moderator band here. I can see here. That means it is atrioventricular concordance is there. Atrioventricular concordance is there. How to put it? Now I am catching the things. So you people can see. So once you are catching this, put the color in case if you want it only. So you can see I'm putting the finger. See, blood is flowing like this towards the probe. It is coming red. Okay, I can see some amount. There is some red bluish color. I'll try to put the continuous wave Doppler. See, what I am seeing is different. See, you can see very clearly now. You people can see, I am trying to put. It's going towards the tricuspid. So there is no, I am not finding any tricuspid regurgitation in this. I'm not finding any tricuspid regurgitation in this. Means how to see, sir? I am seeing like this, reverse of the heart. So tricuspid regurgitation means blood should flow away from the probe. See, you can see now very clearly. Okay, I am putting the color. See, I'm not able to see anything. Only I can see E and A wave. See, this is somebody was telling what is E and A waves. Okay, so now I will talk about E and A waves also. Somebody was asking me what is E wave and A wave. You people can see this. See, I am putting the mitral valve. This is the mitral valve. Put either pulse or whatever the wave you want and collect the see, this is the one. See, you people can see this. There is a very clear, beautiful E wave and A wave I can see. E wave, you people can see E wave is less, atrial contraction is more. Usually that will be there in the preterm baby more. Atrial contraction. So indirectly it is telling atria is pushing the blood to the right ventricle. Right atrium is pushing more blood to the, what is it? Where it is pushing to the right ventricle. This is E wave, early filling. A wave, that means atrial contraction filling. Okay, it is slightly high. It is common in the immediate delivery. It will stay for a long time in a preterm baby. As term baby, within 18 to 24 hours, as everything pulmonary will improve. So E will take more and E will come early. E means because blood is easily can flow. Then A will start decreasing. If that A wave is started increasing, let me repeat, if A wave is started increasing, that means right ventricular is having trouble. It's not able to take up the volume. That time right atrium is taking the action to fill the blood. Like LA is taking the more action to fill to the left ventricle, like that. So E is to A. E means early filling of the right ventricle or left ventricle if it is a mitral valve. A wave means atrial contraction. So needs since it is a just now delivered baby, A is little more. That is called E and A wave. Okay, now I was talking about just like this. I'll go step by step. I am seeing. So since I am not able to see the tricuspid regurgitation, I am not able to show you what is RV-SD ratio. And I am not able to RV and A. See, RA. See, this is RA. This is RV. This is center. I bought it, trying to bring it to the center. Okay, trying to bring it to the center. I am able to see this. Okay, naturally, almost everything is okay, acceptable. There is no problem. There is no problem. I feel everything is normal in this baby. Even aorta is going towards that, and the pulmonary. See, you can see even this is the. See, this is a what is this? Anybody can tell me what is this? What is this? Anybody? This is pulmonary artery. No, this is pulmonary artery. Okay, this is aorta. This what you are seeing is aorta. This is aorta. This is LV. This is aortic valve. This is aorta. What you are seeing. I am turning my probe. I am turning my probe slightly higher. And from here, I am opening the, see, I am opening. This is called crisscross. I am opening. Can you people see this? RV, it is opening pulmonary valve. It is, so this is aorta. This is crisscross. That means TGI is ruled out. Okay, now come to the other one, TAPSE. You were asking, just put the probe once again into the same place. Okay, put that M mode cursor. I stopped it. So now you should tell me which one is systolic, which one is diastolic. It is coming towards, this is systole. It is going away. This is diastole. From here to here, the distance. From here to here, it is definitely, if you will take from here, I am just trying to measure it. Calculator idiyama. Okay, I am able to say this very clear because that is excursion. Almost it is going. It is how much? Almost distance is 0.9. Almost 0.8 or 9, something like that. It is there. So come to the, if it is, if it is like that, freeze it. That is a freeze it. Okay, now you are seeing. Take this distance, just measure it from here. This is the systole, and take any type of measurement from here. 1 point, take it 1.7. That is systole. Select it. Come to one more. One more. From here, it is 0.6. So 1.7 into 1.7. See here 1.69 is there. Make it 1.7 divided by 0.6. You understood? See now, this is very good. It is almost coming. So almost it is 2.8. It is not going. Okay, 4 or anything, because as it decreases, it is dangerous. This baby is having absolutely normal TAPSE. But TAPSE, is it very good to indicate? Absolutely, in a neonate, it is a lost in a whether should do or not. Okay, number one. Now come to the other one. So now still I am in the MPI. Somebody has asked about the MPI. I am going to show you now MPI. So first TR and RVSD. SD means systolic and diastolic ratio. Since TR is not there, I am not able to show you. Then come to the, what is that? PR. PR is also not there. PR, okay. I didn't check PR. I'll come to the PR later. Okay, now what I told you, I'm going to show you the, see where I am keeping, somebody can tell me where I'm going to keep. Now I am going to keep very clearly in this. What is this place? Anybody? Intraventricular septum, left ventricle, right ventricle, tricuspid valve. This is opening. I am putting in between. If I put in between, I am going to see left ventricular MPI. If I'll put here in between, what I will see, I will put the right ventricular MPI. So now slightly, if I'll take this, see exactly it's good. I'm trying to put here. Warmer on my baby colder. Warmer on my system. See, this is tricuspid valve. I am putting here. Call the sister I told you. ಜಾಸ್ತಿ ಇರುತ್ತದೆ. I am going to the subcostal view. I am going to the subcostal view. Number one, in the subcostal view, I am going to show you. No. Danya, ಸ್ವಲ್ಪ temperature ಜಾಸ್ತಿ ಮಾಡೋಕೆ ಜಾಸ್ತಿ cold ಇದೆ. So take this. Okay, the probe. So you can see both the arteries and everything. Not to worry much. Put it here. See, you are able to get, dear friends, I am putting the cursor. You are able to get EA and A wave, and at the same time RVOT also I am able to get. RVOT also I am able to get. So I told you MPI can be diagnosed by two methods. This is a single method you can diagnose. If you are very confusion in the single method, so don't go for it. Just if you are a beginner, go for simple one. Take like this, put the probe in the apical. Okay, I have put it in the apical. Then go to the anything and put the, so what is this view? Where I am putting the cursor? Example, mitral. I am taking the mitral one, very clear. I am putting the mitral one. Yeah. My cursor is in the mitral. I am getting both. Anyhow, no. I have got now in between the mitral and aortic. What is this down one is aortic flow. What is above is E and A wave. So how to tell? Please, anybody can explain to me now. I was telling you. Okay, this is the left ventricular outflow tract, aortic flow. This is aortic flow. This is a E and A wave, mitral flow. Okay, what is relaxation time? So now I want you people to see from here to take this much. If you want to show you, this is isovolumetric relaxation. What is it? Contraction pre. See here. Can you people see this where I am putting IVCT? After this contraction, what happens to this? After this contraction. So this is a 1. You people have seen. Now there is a second thing. Come to anyone, any you take. If you want to take from here, take this. Take this. I am happy. 1. If you want to take from here to here, there is some relaxation time is going on. Take this. Properly, if you'll keep, you'll get it. Then if you'll take IVCT, IVRT, instead of all those things, clear, 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 clear. All those things at a time, you take the measurement from here. Take till, where is the next one? Till here. This is one cardiac cycle. How one cardiac cycle? This is the ending of one cardiac cycle. This is one ending of cardiac cycle. So I took it as an now enter. How much is the time? Example 0.526. So measure it, my dear. Calculate the go. I'll tell you. This is the full A. Okay, this is A. Okay, write it down in a paper also. Take a white paper, write it down. Here only. Come. You slowly write. Put it here. A minus B divided by B. Small. A is equal to 526. Example. 526. B. Come to the B. B is ejection time. 216 divided by 216. Can you take calculator? See, 1.4. 1.4. See, I am happy. I am happy. So why I am telling all those things to you is, this is MPI. I am taking from 1 to 1. So this is what I have taken full isovolumetric contraction time plus relaxation time, ejection time. Full I took. So that is full. Then ejection time I deducted. So that means I have taken only isovolumetric contraction plus isovolumetric relaxation divided by ejection time, B. So I got MPI values. Now you understood how to take MPI. Now come to the, what is that shape? One more view of how to take the other things. Just let me tell you. Now I am going to see the parasternal long axis. See, for that I have changed my cursor to this. Once again, I am going here to the parasternal long axis. So for parasternal long axis, my cursor towards the left shoulder. Once again, my cursor towards my left shoulder. That means baby's left shoulder. Oh. I am able to see the parasternal. This is the parasternal long axis view. I am able to see. Now I am bending towards the patients. See, you can see the tricuspid now, please. Anybody can see now tricuspid very clear. Once again, baby is moving. Sucking pedal. See, you people can see now tricuspid valve very clearly. I am turning my probe towards the left. You people can see tricuspid valve very, very clearly. You people can see very clearly. I am putting the color. Then in case if I want, I will put my see now you can see once again you can see your mitral valve, tricuspid valve. I am putting the color. Oh. No. Okay, I am putting the continuous wave Doppler. I am not finding any tricuspid regurgitation. Same thing I am finding, same E wave with slightly the other things. Otherwise, I am not able to find any even scale if I will increase. See, 5 I made the scale. Scale means where anything is there or not. I am able to find simple. See, you people can see in this still tricuspid very good flow. And I am putting once again the probe. I am not able to find even little PAH is there, because even bluish color is also not there. So 2 I have seen and I told it is not there. So this is the way. Then any other way you can see. Go to the. So 2 views I told you. One is apical view, another is long axis view, another is subcostal view. Now we will go to the all the things right ventricular I told you. Now go to the PDA view. So PDA, how to see the PDA view in this? Please see now higher, slightly turn. Okay, see there, dear friends. I'll put more gel. So I am able to open the. You people can see now very clearly. Okay, what is this? If a cursor, you people can see the cursor. This is the cup and saucer, slightly upper view. That's called a PDA view. I am going to come. This is aortic valve. This is the RVOT. This is the view where I am going to see the pulmonary valve. This is the pulmonary valve. You people can see, in case if you are not able to see the color I am going to put it. See pulmonary. Can you see PDA, small PDA? I think so. You can see more better now. That is having still PDA is having both still PDA, and I am see now you can see more better PDA. Do you think this is all PDA big one worm? No, this is the only smallest PDA where I am putting my hand. This is the one where small PDA is there. That is a jet of blood. All the other things are jet of blood. So now I am going to show you. See, this is an MPA. You can see MPA very divided very nicely. You can see. Now I am trying to put a color. I'll take the pulse Doppler. This is each respiration and cardiac. This will move. This is one big problem. Can anybody tell me what is this? PDA I am taking, almost I am overlapping on MPA. So down one is right to left shunt. This one is left to right shunt. Once again, let me show you. See, this is the way I am catching the PDA. Okay, this is the way I am getting the PDA in this view, very clear. Putting the color. And I am putting the power Doppler. Very good. And I am trying to, whatever the textbook you people are able to see, you are able to see in this view, very clear textbook view. Now we will take whether it is more than 30%. Definitely in this view, it is more than 30% according to me. Okay, but so PDA, why we didn't find in TR, what is it, TR, why we didn't see TR in both the things? That is the reason. Please try to see the other angles also. But this angle is not always accurate. Okay, now come to from here. See, from here, whatever I am seeing, this to this, sorry, enter. Till here, I am finding one cardiac cycle. I am finding one cardiac cycle. Can you take the paper and pen? Can you keep here? Okay, right here. Complete cardiac cycle is 472. 472. Okay, 472. Yeah. So right to left shunt is once again right to left shunt. That means from here. Machine automatically takes 162 divided by how much in 472? How much percentage is there? If it is 172, this percentage is 450 and 200 barbe. It's almost 29%. Huh? See, it is almost near 29% because it is bidirectional flow is there. It is 8 o'clock delivered baby. You people can see it is how I have calculated less than 30%, more than 30%. So you people can see now. Yellow 169. This is the way you have to complete cardiac cycle. How much is right ventricular cycle? If you will do this, this is the best way. Now, in this thing, can I diagnose PAH? Yes, you can diagnose PAH in the PDA flow. Since it is less than 30%, so what should I take? I should take left to right shunt. So what I am doing, I have done this. I have taken the velocity. Automatically this itself will give the, what is it, pressure gradient. See this, whichever the maximum, the pressure gradient. Okay, I have taken from here, sorry, clear. Yeah. See, 3.2. Almost if you'll take here 2.5. 2.5 into, see, you take 2.7. 2.7, come here. I have taken 2.7 into 2.7. Okay, this is the calculation, dear friends. Pressure is equal to 4 into V2 square. So pressure is equal to 4 into 2.7 into 2.7 minus systolic BP. I don't know what is the systolic BP. I didn't see. So 4 into 2.7, 2.7, how much?
29.16.
See, 29. Okay, make it 30, round figure. Suppose if systolic is around 40, 50 something, so it is coming minus. So there is no much pulmonary arterial hypertension. If the, come here, this one is more than 30%, then I should have taken from here to here, then I would have added plus systolic. Since I have taken it is less than 30, I have taken from here to here, so it is minus systolic. So you people understand, from PDA also we can diagnose PAH. Okay, any doubt we will discuss in the discussion. So what is pulmonary art? Now we'll go to RVOT, everything we finished, PDA we finished. We will go to the pulmonary artery. Come here. Once again, pulmonary artery, how to see? I am taking to the short axis view. Once again, please see there. See, now I can see the cup and saucer, very good appearance. And I am able to see the pulmonary artery, pulmonary valve. Yes or no? I am keeping pulse where? I am keeping in the exactly in the pulmonary valve, next to the pulmonary valve. And I am pressing this. Sorry. See, I am taking the pulmonary valve. I was telling you people, this is like this. This is a little sharp because there is some amount of pulmonary mild resistance is there, but there is no notching. No notching. Number one. Number two, what is meaning of right ventricular ejection time? This is called a right ventricular ejection time. Complete is a right ventricular ejection time. How much is this time? Is okay. See calculation. Now, thank you. See, right ventricular pulmonary accentuation, pulmonary artery accentuation time divided by RVET. Now we have taken RVET is equal to how many seconds here? Example, this is 0.148 seconds. So remember 148 seconds. Now pulmonary artery accentuation time. What do you mean by that? Sorry, I have not calculated. One second, dear friends. I have not calculated. Now I am going to calculate how much is the time. Okay, I'll take once again. I'm keeping the probe pulmonary artery. I am taking the from here. Okay. 2, 2, 3. Example, I have taken now. Right ventricular is 2, 2, 3. Pulmonary accentuation time is, once again I'm calculating in the same one from here to here. See, this is the one, approximately this one from here. Once again, this is here. almost this will come exactly like this. Okay, I have to take a little more. Yeah. See here, what is the time? 0.61 divided by 0.61. So calculate how much it will come. It will come almost 0.02. It is very this thing. That means what I want to tell you people is right ventricular from here to here, from here to here. If you'll take, now I'm taking one more thing. Hold on. Do like this. Go to this one. Complete one cardiac cycle, one full ejection time. Okay, I have taken. How much it is? Time is 236. Same thing. It is coming 236. How much is the percentage? I want to see. Yeah, almost it corresponds to this. This is corresponding to this. Okay, this is 6.7. Same it is coming. That means mild pulmonary hypertension is there. Mild, moderate, severe. How to diagnose this? Once again, PAAT, if it is very small, the PAAT is very small, that means more pulmonary arterial hypertension. So if you will divide, what happens? It is coming 0.3. Up to 0.3 and above is good. 0.3 to 2 is moderate. Less than 0.2 is very severe pulmonary arterial hypertension. So it is coming in between the moderate to mild. If it is coming moderate to mild, we'll hold on. It will, because it is 8 hours. It will, once the pulmonary will open up slowly, it will decrease. Then what else you people should see? There is no pulmonary regurgitation as such. Now, anything else you want to see? Where is the paper? See, I showed you the size pulmonary artery diameter. How to take the diameter? Please come here. From here to here. This is from here, pulmonary artery diameter, then till here. Okay, how much, sir? I don't know. To remember, you people can go to the Google Z scores of the pulmonary artery diameter. So from 800, sorry, 5 was to, I think so I have seen around from 800 grams or 600 gram or baby up to all the ages, there is a Z score is there and mean is there. Pulmonary artery diameter. Okay, you can see it. Then pulmonary flow I showed you, pulmonary diameter I showed you. What is PAAT, RVET I showed you. Systolic extension, that is not there here. Ductal I showed you. TAPSE I showed you. Almost everything I showed you today's class. Any doubts, please, you can ask me right now. Yeah. Any doubts, you people can ask me right now, dear friends.
So can you show the ductal assessment of PPHN once more?
ऐसे पकड़ना यार. I am putting the pulse wave. Okay, I have taken the measurement. Whichever from this end, one cardiac cycle you take, dear, to this end. You have taken. Now you take only right to left shunt. You see it. Now the first one is 520. Calculator. First one is 520. That is complete. In that 50%, Girija, can you calculate? 520,169. 520,169 is how many percentage? You can see the time. 169,520. How much percentage? See, now it is coming almost 33. It is it's just coming down slowly. See, previously I got 29.33. So if you will leave another half an hour to 10 minutes, it will come down. So anything else you want to see? See, if it is in the borderline, just follow it. But see completely structural heart disease. Dear friends, before closing the PDA, I want you people to see any structural heart problem before jumping and starting brufen paracetamol. And one more thing, anything is more than 30% in PDA unless otherwise, and go to the right atrial. See here, now I found 30%. I found 30. Now I know that this baby just now delivered. This much pulmonary artery tension to rahega. It will be there. But now I will see the ductal. What is the AST flow? Now I will go up and down. Same thing. I have gone to the up and down. Now I'll come to the subcostal. Yeah. I can show you. There is no, see here. You people can see. There is a left to right shunt in the AST. See, left to right shunt in the AST, there is no blue mark. That means I am not much worried. I can wait for this baby. Since I am a doctor, I know what is pathophysiology is going on. I can wait. See, you can see AST very clearly. Left to right shunt which is red. Then anything else you want to ask me? Anybody, please? Either in the PDA, either in the any structure, how to see, or PPHN till now. Next class, we will show you how to do the all the global left ventricular FS, everything. Next class, we will show you. Thank God we have finished very fast. Anybody wants to ask anything?
Dinakaran, Dr. Rajiv here. Can you
Dr.
hear?
Rajiv, very happy to talk with you.
Yeah, have you looked at the, tell everybody who's in the class today that never forget the four pulmonary veins. Huh? Whenever you look
I
for.
didn't get you. Pulmonary veins, you want me to, I will show you pulmonary veins.
Most important, don't miss it.
No, I will right now. For pulmonary veins, try to take the higher frequency probe or lower frequency probe, it doesn't matter. But I am taking the high frequency probe. Pulmonary veins can be seen either in the subcostal view or in the apical view, number one. Then pulmonary veins can be seen in the crab view. You understood what is meaning of crab view? Suprasternal, where third angle view is called a crab. What is suprasternal, where horizontal axis posterior view. Show you. Number one, come. Oh. Rajiv, see, this is the one. Please concentrate. So I can see the 4-chamber view very clearly. I can see number one, and I am putting my finger here. This is the left atrium, left ventricle, right ventricle, right atrium. I can see this one where I am seeing very clearly. Slightly, I'll go posteriorly. Okay, I am able to see the two veins here. Left superior, left this thing. But what I easily available vein is usually right upper pulmonary vein. So if you'll put the color, there is an art here. Catching is an art. Try to put the scale down. See, what you mean by scale is this. Try to put the scale down because pulmonary veins are a low flowers. See, you are able to see now one. It is a left superior pulmonary vein, left superior pulmonary vein, right upper pulmonary vein. Okay, you are able to see, and even this thing also you can see from here. Blood is because I am putting from the left, blood is flowing like this. That is this is from the left atrium, blooding flowing flows to this. That is the reason it's becoming blue. Now I am seeing very clear. Okay, I can see even inferior, what is that, left inferior pulmonary vein also I can see, because this is the way, many ways, and try to decrease more. You will get a better image. And this is one view I showed you how to see the pulmonary vein. I have not gone to the Doppler. Now I will show you right pulmonary vein in a subcostal view. How to catch it, I will show you. So we need a higher probe now. I need a higher probe now. I'll show you. So, dear friends, whenever you're buying, try to buy both the probes, pediatric probe as well as the neonatal probes. It will be useful. See, now you can see, because I'm going to the subcostal, it needs a little deep. Okay, now I'm putting the color. See, you can see the better. You can see the very good. This is right ventricular outflow tract. Yeah. You people can see now what is this? This is the right pulmonary vein, upper right pulmonary vein, you can see. But can I measure in this view? I cannot measure in this view because it is perpendicular. I cannot put the Doppler in this view. Doppler always I have to put it in the apical view because almost it is near to the perpendicular. Now I showed all the three veins. So I have ruled out the TAPVC, at least three veins. Now I go back to the Doppler of the right upper pulmonary vein. Okay, how to go? Just this. Okay. I can show you now right upper pulmonary vein very clearly. Slightly decrease the, still more the things. That is called whatever the RPA or whatever. Then put the pulse Doppler there. I am very happy. Number one, what classical textbook S wave, D wave can be shown. If you are having the patience, I can show you classical S wave, D wave. A wave is also difficult, but I'll try to show you. See, number one is this. Okay, I'm getting now. Yeah, I'm putting the pulse Doppler. Okay. See, A wave also I can see. S wave and D wave almost it is mixed because of the tachycardia. Once again, let me tell you, S wave and D wave is mixing. S wave is the systolic from the valve. D wave is from the diastole. A wave is also there. But one thing is almost it is mixed because of the tachycardia. As the heart rate comes down slowly, everything will be there because heart rate is now at present is 170 to 180. So S wave and S wave, once again, S wave and D wave is mixed. A wave, it is very evident. And how you're going to see if it is a pulmonary vein stenosis, it will become continuously, it is more than 1 meter per second. Yeah, all the pulmonary veins you should check. It will become 1 meter per second. Number one, only I have seen right pulmonary vein. Okay, 1 meter. Otherwise, initially it is 0.6 to 0.8 meter per second. Within 24 to 48 hours, it will become 0.6, then 0.4, and it will be very low, 0.2. If the pulmonary stenosis is there, the stenotic, that it will be continuous, like how venous hum is there, it's like a continuous, but it will be more than 1 meter per second. Okay, anybody, anything? See, you can see this is very clear. You can see now what anybody can tell me what I am showing you. What I am showing you, anybody? Now slowly I am coming down. This is aorta. Yes or no? And I am coming up. I am opening the pulmonary artery. It is, see, pulmonary artery is going like this. Pulmonary artery is going like this, and aorta is like this. So it is crisscross. So see, this is aorta. This is pulmonary artery. Pulmonary artery is superior towards the almost lateral. So there is, and I can see from here also PDA. If there is a PDA, I can see from here also. I have to increase the. See, anybody can see PDA here? Something is coming red. Anybody can see PDA? This is the RPA, LPA. Near LPA, you can see red. You can see red. This is a PDA. So PDA can be visualized even subcostal, modified subcostal to apical, in between angle also you can see the PDA. So you can see the right ventricle, pulmonary artery, sorry, pulmonary valve, pulmonary artery dividing into the right pulmonary artery, left pulmonary artery. Near that you can see PDA. Any doubts? Anything you want to ask me? If Kamal sir tells yes, I can close the session.
We can close, sir. I think we have to go to the bedside and use our bedside echo machine and try it out for ourselves. And definitely we'll have lots of doubts to clear, sir, when we come back for the next class.
Thank you, Dr. Rajiv. Thank you, Dr. Rajiv. Thank you, Dr. Kamal, and all the ICH people and everybody who have attended. Many people have attended. Yeah. So, Rajiv, any comment you want to give?
Yeah.
Prashant, any comment?
Yeah, can I make a comment, Dinakara?
Please.
See, whenever we treat PPHN, no, one thing we should never forget is if it's not responding adequately to your management, we have to look at PPVC. Many times it has fooled even my senior colleagues. So whenever you have a pulmonary hypertension not responding adequately in 24 to 48 hours, you have to again look back at your pulmonary veins because they all mimic the same. A TAPVC will mimic a pneumonia, and you will think it's a meconium aspiration pneumonia. It will be a TAPVC. especially the infracardiac variety, very difficult to pick up. So always have a second
No,
look.
infracardiac is, I think so. Next, we will, whenever congenital heart problem is there, I'm going to do every Tuesday and every Friday, 2 o'clock to 4 o'clock. Like that, totally 15 classes are there. In that 15 classes, that is also congenital heart problem, common, not complex. What as a neonatologist should learn, I learned. That I will show you.
Correct. Very good.
Kamal sir. Kamal sir, I cannot hear you.
Sir, unmute, sir, unmute.
Yeah, I muted. The video was very shaky.
sir.
The video was very shaky today. When we were, it kept moving a
Video,
lot.
I think so. Sir, our postgraduate did not take food, sir. Hypoglycemia. Sir, and 10th I am expecting my video cameras and other things. That is the reason I am sorry, sir.
No problems. No problems. You conveyed everything you had to convey. You conveyed everything what you had to convey. But this video is a little shaky. That's the only thing. Otherwise, it was very nice. All the points covered.
I will tell my postgraduate. Don't. Sorry.
Thank you.
Sorry.
You can have lunch and then shoot the video.
Prashant,
Thank
you want
you.
to tell anything? We'll close up.
Fantastic, sir. But today we had little bit of technical issues. That's why it was coming and going for me.
Yeah.
So voice was, I was having problem with my technical thing. Otherwise, the lecture wise, as usual, you always rock. You teach us right from scratch to everything from holding a probe to getting a views. So it's like a complete package for beginner.
Now, I should tell
people
thanks
already
to
have.
my baby. Baby did not cry.
Yes, sir. Yes, sir. Both all three classes. I mean, baby has been very, very friendly. It is allowing all of us to learn. Thank you very much, sir, and thank you, Kamal sir.
Thank you, sir. Thank you.
Thank you, sir.
Kotreshi,
sir.
Yeah, very good presentation by our Dinakar. It's a wonderful idea about how to put the things in a right way to understand our PGs also. I'm at the same time, I welcome PK Raju, who is my mentor for this program also. He is also on the line.
Thank you, sir.
Thank you, Dr.
Thank you. Thanks.
Thank you, sir. Thank you, sir. Thank
We'll
you,
see
sir.
you
Have a
next
great
class.
day, sir.
Yes, sir.
Yes,
Thank you.
yes, sure.
Sure.
Yes, sir. Yes.